This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parks, physical therapist and your host, and today I'm joined by Liz Bayley for a conversation about foot and ankle injuries, common mistakes, tips and tricks. We discuss common foot and ankle injuries by region, key tips for subjective and objective assessment, treatment strategies, rehab mistakes to avoid, dancer-specific insights, and more. Liz is a specialist dance physiotherapist based in London. She has worked with top performers from Disney's The Lion King, international ballet companies, and elite athletes across football, basketball, and the UAE Pro League. Liz teaches globally on foot and ankle rehab and dance physio, and recently spoke at Sports Kongres 2025 on hypermobility and injury prevention in dancers. She also contributed to the upcoming edition of Clinical Sports Medicine and continues to support professional dancers worldwide via telehealth. If you find our conversation informative, don't forget to subscribe, hit the notification bell for updates, give us a thumbs up, and share this episode with colleagues who could benefit from these insights. Thanks for tuning in, and now let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like Sarah Health. Remote therapeutic monitoring sounds great, but also difficult. Sarah Health makes RTM simple and easy for your patients and providers. Check out sarahealth.com/PTProTalk for a special offer. Hi Liz, welcome to PT Pro Talk. How are you today?
Hello, I'm good. Thank you very much for having me. It's really hot in London. We've got a heat wave at the moment.
Okay, it's getting warm here in Bermuda as well, so I guess the summer is here. So Liz, let's just get started talking a little bit about yourself and your career.
Okay, so my career started when I was about 3 because I started as a dancer, and I was a professional dancer when I grew up. So that fed into the fact that I'm now a dance physiotherapist. I started dancing from a very early age, and when I went to university, I did psychology because I was trying to be sensible, and I thought I'll get an academic degree so that I have something to fall back on. As soon as I graduated, I became a professional dancer, and I did that for about 15 years, all around the world. And I specialised in Latin and ballroom. And then I got injured myself a lot, which got me interested in physiotherapy and osteopathy and everything that I used to get myself as a performer. And I just found it fascinating. I loved anatomy. So I decided to study sports therapy because I wanted to go into sports. So I was a sports therapist for about 7 years. And then I decided that I wanted to go further with my studies and be better qualified and have a better understanding. So I did a master's degree in physiotherapy. And that was in 2016. And I've been a physio since then, so nearly 10 years now. And as I said, I specialise in dance physiotherapy, and then I also specialise in the foot and ankle because dancers, everybody will know, injure their feet and ankles a lot. It's probably around 60% of the injuries that you'll see in dancers. So I effectively now specialise in foot and ankle as well. And I work in London, in the West End. So I have worked on most of the big shows in the West End. 2 of the biggest ones that I did for 3 years each. One was Wicked and the other was The Lion King. And I was the head physio on The Lion King. I learned a lot on that job. We got injuries to every part of the body because, of course, if anyone's seen the show, they have puppets, they have very energetic dancing. So that was a fantastic job. I loved working there. And now I'm on Matilda the musical, which is less dancey. But I go there once every couple of weeks to see the more complicated injuries, and I work with the principals, and I have my own clinic in the West End of London.
Before we continue our conversation, I wanted to take a quick moment to present you to our sponsor, Neck Care.
Traditional neck assessment methods often fall short of providing a full picture, overlooking movement control and sensory motor integration. That's why a physical therapist developed the Neck Care system to provide reliable assessments of sensory motor integration, proprioception, and range of motion. With objective data and visual results, physical therapists can better understand neck impairments and design targeted treatment plans for optimal outcomes. If you treat neck impairment in your practice, visit neckcare.com to learn more.
And now, let's get back to our conversation. That's awesome. that's a super cool career and story and everything. So, and as we mentioned, we know that foot and ankle are a big part of dance injuries, right? So that's what I wanted to focus today, since you have so much experience on that area. So would you like to break down that for us, maybe by region, different parts of the foot, and start just talking about the common injuries, and then maybe walk us through some points that you focus on, the assessment, subjective, objective, and things like that?
Yeah. So I actually teach a few different courses on the foot and ankle now, and some of them are more diagnostic and some of them are more rehab focused. But it can be useful to break the foot and the ankle or any body part into regions when you're looking at diagnosis or trying to understand the anatomy, particularly looking at differential diagnoses. And on the courses that I teach, I do the foot and the ankle in one day, but it's so difficult to get all the information into a day. I mean, you could do a week very easily on foot and ankle, and I could do just the lateral ankle in one day. That would be far better, actually. But trying to give people enough variety that they go away and are able to apply things in clinic. So I don't know how useful it would be to just focus on the lateral ankle, but I could easily do a day just on the lateral ankle, in the same way as people do day courses on, say, the ACL, because in lateral ankle, of course, you have lateral ankle sprains, which are probably the most common MSK injury going in every type of sport and outside of sports, because people step off the curb or the path. What do you call it? A sidewalk. People step off the sidewalk and sprain their ankle all the time. So ankle sprains are incredibly prevalent in the population. But when I teach the day foot and ankle course, I do diagnosis for the ankle, and then that's split into different regions. And then as part of the afternoon, I do rehab of the foot. I don't even touch on the diagnosis of the foot, because you can split the foot into the rear foot, the midfoot, and the rear foot, the midfoot, and the forefoot. And just the diagnosis alone, you can easily do over a day or two. So what I'm saying is it's a complex area with many different differential diagnoses. But some of the most common things that you'll see will be lateral ankle issues. So they would be, as I said, sprains. So the most common is a lateral ankle ligament sprain. And then differentials for other types of sprains would be syndesmosis or medial ankle sprains as well. Once you have a sprain, there's a high chance of you going on to have a secondary issue from that. We know that around 40% of people will get a chronic ankle instability. So if sprains are common, nearly half the people that sprain their ankles will have an ongoing problem. So you're going to see that a lot in the population. Also, around a quarter of people will get some kind of impingement. So whether that's anterior or posterior impingement. And then you've got other lateral ankle issues, so perineal tendons, osteochondral defects of the talus, bone stress injuries of the talus, neural pathologies, the superficial perineal nerve. So there's lots of anatomy around the lateral ankle. If we go to medial ankle, you're thinking more, the most common injury you'd see, and most people would think of, would be the tibialis posterior tendon. A good differential aside of that a lot of physios forget about is the FHL tendon, because they both run down the tarsal tunnel together. But the FHL tendon, the flexor hallucis longus, goes into the big toe. So looking at big toe movement when you have a suspected tibialis posterior tendon issue is a good way to differentiate whether or not it's FHL or tib post. And like I say, that might help people not miss those cases, because the management does change a little bit. You'd have far more foot rehab with an FHL issue than you would with a tibialis posterior tendon issue. However, my bias for a lot of things is foot rehab, so I put that into everything. Any kind of ankle injury, if you can include foot rehabilitation in that, it should improve your outcomes. It does for me clinically anyway. There's not great research to support that, but we forget about the foot, and it's almost as if the ankle is the end of the body and then there's nothing else below it. And when I learned about anatomy at university, and about pathologies, for physios, it kind of stops at the ankle. And then we get taught about plantar fasciitis or plantar fasciopathy, and that's kind of it. So sometimes I feel like my courses are in demand because we don't get taught about the foot very well as physiotherapists, probably because there is the branch of podiatry, podiatric medicine. So there is a whole area that specializes in that. But as physios, if we can understand the foot better, I think our ankle rehab can be a lot better. And it relates to all things down the lower limb, the knee, the hip, even the back. So yes, don't forget about the foot is one of my key messages. So if we go back to zones of injury, so we're on medial ankles. So yes, so I see lots of bone stress injuries, so navicular bone stress injuries and medial impingements, medial ankle sprains. Then if we go to the rear foot or rear ankle, posterior ankle, of course, the key thing that people will be seeing in clinic is Achilles issues, Achilles tendinopathy, paratendonitis, Achilles tendon ruptures, and then you've got posterior impingements, you've got insertional Achilles tendinopathy, calcaneal bone stress injuries. There's a multitude of different pathology in the posterior ankle, plantaris tendon type issues, plantaris tendon ruptures. And then, like I said, if you go down to the foot, that can be split into 3 different areas. So rear foot, you're thinking more plantar fascia, Baxter's nerve, fat pad issues. Midfoot, the most common injuries I see would be midfoot OA, so arthritis in older people, or synovitis in sporting populations. And that presents as pain over the dorsum of the foot around the tarsometatarsal joints. I see quite a lot of second opinion Liz Frank injuries. Now that's because I'm a foot and ankle specialist, because Liz Frank injuries are actually quite rare. In sports, they're not as rare. It depends on the sport. If you work in rugby or like the NFL, you would see Liz Frank injuries more commonly. But as in a population, Liz Frank injuries and ruptures are not that common. Yes, I probably have a bias. I see more of those than the average physio would. And then, of course, I see lots of forefoot issues. So that would include the umbrella term of metatarsalgia, which is mainly talking about the lesser metatarsals. So that would be capsulitis, synovitis, neuromas, bursitis, stress fractures to the metatarsals. And then in the big toe, hallux valgus. And hallux valgus isn't a problem by itself, but it does tend to cause painful joints, bursitis, and then problems with function going forward, because as the hallux starts to drift laterally, it affects the foot function, and it's often secondary to a hypermobile foot. So that's another thing that carries other issues with it. And then things like sesamoiditis, so the little bones that live underneath the big toe. I see a lot of that. And again, quite a rare injury overall. It's more common in dancers, gymnasts, runners, people who work barefooted, definitely dancers, and particularly Irish dancers, to be very specific. I work quite a lot with Irish dancers. I mean, England is right next to Ireland, but somehow the Irish dancers have worked out they can work with me over Zoom. So I do lots of international or like local international work with the Irish dancers who get lots of forefoot issues, lots of stress fractures and sesamoiditis. And that's because they dance on the balls of the feet the whole time. They never let their heel drop. But that's a very specific injury for a very specific cohort. But I think that covers the injuries that I see and some of the most common ones. I know that's a lot of information.
Just a quick pause to share something exciting. I've been working behind the scenes on a tool to make prescribing home exercises easier and faster for PTs. It's built based on feedback from therapists who have told me they are tired of clunky search tools, limited customization, and complicated sharing. I will be sharing more soon, but if you're curious and want early updates, you can join the interest list using the link in the show notes. All right, let's get back to the conversation. Oh yeah, that's a lot of information, a lot of different injuries. So now, how would you like to go about maybe a few tips on subjective and then objective? Because I know it's a lot. So just maybe the most important things that you see?
Yes. So, I mean, for any subjective, the key thing is trying to work out whether this is an acute injury or a chronic injury. So has it just happened, or was there some kind of trauma involved, or is it something that's come on over a long period of time? Because often that makes it quite easy to completely forget about certain diagnoses. Like if it's a chronic issue, we're not thinking about, an ankle fracture, or if it's something that's happened suddenly, we're not thinking so much about something like a tendinopathy, although it could be a tendon tear, in fairness. But trying to work out the duration of the injury, how much it affects the person, can they walk? So the thing about foot and ankle is that people need to walk to get around. It's very hard to function if you have a really bad foot or ankle injury. That's why it affects people so badly. I mean, if you get an injury in the upper limb, you can immobilize it probably a little bit more easily. Although, of course, we need our upper limbs just as much to live. But if you injure a foot and you can't walk, it really does affect people's function. And even more so if you injure foot and ankle and it affects their ability to do sports or to run. Runners are a special breed. People that run for exercise don't want to stop running. So if a foot or ankle injury stops them from doing that, often it affects their mental health. Obviously, all the sports people I work with professionally, it's a huge part of their identity as well. So trying to work out how badly it's affecting them, what is their function, how are you going to be able to offload them in the meantime so that they can recover a little bit but still be able to get where they need to go. So like I said, you can offload the foot and ankle in various ways. You might have to immobilize them in a cast, right down to just giving them some kind of orthoses or podiatry felt to offload one of the metatarsals. So trying to work out, how you can keep them functioning and reduce their pain and offload the area that needs to be offloaded is key. And the great thing about the foot and the ankle is that you have footwear. So if you work with, this is not true for dancers because dancers tend to dance in bare feet. Also martial artists and gymnasts, those are difficult populations because they tend to do their sport without any footwear. So if you have an injured foot, even if you have a sesamoiditis, often you can keep people working through that with the right footwear and orthotic treatment. But if they're in a bare foot, there's nothing you can really do. So they are the more challenging cases. But yes, knowing about simple changes to footwear. So if you have a posterior ankle issue, just giving someone a heel lift or a trainer with a bigger heel to toe drop will really offload a sore Achilles or a plantar fascia. Or if it was anterior ankle, something like an anterior impingement. So a really simple heel lift can be very useful. And then again, various different types of orthoses, with whether you have arch support or metatarsal support, or if you have a lateral wedge, there's all kinds of things you can do to offload parts of the foot. But the subjective is the key to that because you're trying to work out how it affects them, what shoes do they normally wear, what have they done leading up to the injury. So the subjective should really give you the information. That is your diagnosis. So if you've got something like a bone stress injury, the history is absolutely key for that because someone can have pain, let's say in the forefoot around the second metatarsal, and it could be a neuroma or a bursa, or it could just be a sore capsule, but it could also be a stress fracture. But the history leading to that injury is quite different usually. They're all overload injuries, so there might be a peak in activity, for example. But the magnitude of the loading can make a difference. So if someone's intensity of training has gone up, or their rest periods have come down, or for some reason they can't sleep, so their recovery is interfered with, and they've got pain that gets worse during activity and it aches afterwards, and there's a little bit of night pain, maybe mild swelling over the metatarsal, like the dorsum of the foot, I would be thinking a metatarsal stress fracture. I wouldn't be thinking a bursitis, for example. Or a neuroma tends to have a sharper burning, nervy pain to it. So asking about quality of pain, as I say, the training load that led to the injury, or was it traumatic? Or there's so many things that can point you to different diagnoses. So then when we get to the objective, we should be a bit clearer about what we're looking at. So the first thing I'll always start with is people's function. So I'll be looking at their gait. Can they walk? How do they walk? Do they limp? Are they pulling off the sore foot? Are they completely avoiding using the big toe? Do they walk on the outside of the foot? So if it's a fourth or fifth metatarsal issue, are they overloading the side of the foot? Why might that be? Obviously, in your subjective, you're looking at injury history as well. I always ask about ankle sprains. That's the other thing, because they can give you all kinds of problems going forward. Of course, most people have had an ankle sprain as well, so it's how much it affected them. But yes, looking at function, I always look at gait and then heel raise. So a double leg heel raise, where do they place their weight? Are they able to heel raise? Is it painful? Where is it painful? Getting the person to point to exactly the location of the pain in the foot and the ankle is useful, because it's such a peripheral, superficial part of the body that you can be quite specific with the anatomy, and often that will give you the location. If you know your anatomy, it really helps to narrow down the diagnosis. I look at, so that's ankle plantar flexion. I always look at ankle dorsiflexion. That's absolutely key to our function. So I just get people to do a simple knee bend on a double leg. And if they've got a really stiff ankle, you can see it quite quickly. Then I'll assess it more specifically with a knee to wall test. And you can either measure that by centimeters away from the wall where the big toe is, or you can measure it with an inclinometer. And I have a measure on my phone that I use now to measure the degrees of range of motion in the tibia. So that just means that I don't have to find the right wall and set them up. I can measure it wherever they're standing. If you're looking for centimeters as like a normative range, someone should have around 9 or 10 centimeters knee to wall as a normal value. Of course, it depends on the size of the foot. So if they're a very small person with a small foot, it might be less. Or if they're a very big person with big foot, it's going to be more. That's where the degrees of range of motion is more useful, because the size of the person doesn't matter. And the normative range for degrees would be between 35 and 40 degrees of ankle dorsiflexion measured at the tibia. Anything less than 35 can really affect function. So it's useful asking them where the block is. If they have like a block in the ankle, ask them, is that at the front of the ankle or is it at the back? Because if it's a hard block at the front of the ankle, that might be something that's going to be difficult to improve. So it could be secondary to like a sprain as an impingement. I had a patient yesterday who'd had a fracture 20 years previously, and they now had ankle arthritis. And that meant that they had a hard block into dorsiflexion, and they were a bit older. They were actually in their late 50s. And I was thinking, I don't think that's going to improve. So we need to look at ways for them to manage that isn't pushing into that dorsiflexion, because that will just flare them up. So where the block is important. If it's more in the posterior ankle, that might be something that you can stretch or manipulate or mobilize. You can mobilize anterior blocks as well, but again, depends on the patient, the history. Something like a severe ankle arthritis, I don't think will get much better with just mobilizations. You can try, but often it can flare them up if they push into that too much. Then I look at things like balance, so single leg stand. I always use the modified star excursion balance test, which has lots of research behind it. So anterior, posterior lateral and posterior medial reaches. There's normative data out there for what you would expect for leg length. So you can measure the person's leg length and then get a normative range for their reach depending on their leg length. And the anterior reach, if there's a difference of around 4 centimeters or more in the anterior reach direction, that has been shown to be an injury risk going forward following ankle sprains. That was in like an adolescent male population. I think they were basketball players. So you can extrapolate that to patient populations as is fit. But an asymmetry in the anterior reach could be significant. And that could be to do with just postural control of dorsiflexion and balance, not necessarily a dorsiflexion block, like a structural block. It can be just the person's ability to access that. And if you find that, that's brilliant, because you can rehab that. So giving them balance exercises, foot strength, ankle control, and then retesting those modified star excursion balance scores and trying to improve those anterior reach directions. And the posterior reach directions tend to be more effective for chronic ankle instability. So the fact that the test is so sensitive to pick those things up means that I use that same action to rehabilitate people. So I'll give people the Y balance or the star excursion balance test in various forms as rehab as well. And then once I've looked at balance, I'll look at things if they can. So it depends how acute they are, what's painful, what the history is. But I'll look at things like if they can jump. When they jump, is it painful? So if we're looking at something like medial tibial stress syndrome, I want to know how irritable that is. So I'll get them to jump on a double leg. Often they're so sore that after one jump, they say, yes, that's painful straight away, in which case you need to be more aggressive with your offloading. Same for any bone stress injury. Same for metatarsals, definitely, or a talus bone stress injury or navicular. And navicular and talus actually are both high-risk bone stress injuries. So if you suspect that is injured, that needs to be offloaded more aggressively as soon as possible and until a bone stress injury is ruled out for sure. So you have to treat it as a bone stress until proven otherwise. Particularly for navicular, that can be a very, very tricky place to manage bone stress injuries for a multitude of reasons. It has poor blood supply. The bone is in the part of the foot that has a lot of shearing forces. So they are notoriously difficult to manage. So if you get someone with midfoot pain around the navicular, it's painful on jump test, it has a history which would suggest a bone stress injury, offload them as if it's a bone stress even before you have the imaging and say, we're going to do this for your own good, we're going to make sure it's not. And then if it is a bone stress, they've already had a good start. The other key thing about navicular as I'm talking about it is that it should be offloaded non-weight bearing. That's one of the bones in the foot that needs to be not partial weight bearing. The research shows that needs to be non-weight bearing, so actually foot off the floor. So the moral of the story is if you suspect a navicular bone stress injury, get the person off it quickly and then get the right investigations to confirm if it is or it isn't. And if it isn't, no harm done. But if it is, it means you've given them the best chance of recovery. So objective. So once I've looked at function, I'll look at strength. So I always do a single leg heel raise endurance test. There's great data out there for normative values now. There was a new paper published by Green et al. 2024, which showed around, there was another one as well. Begins with V and I've forgotten the name. We can link it in the show notes. There's 2 papers that were published recently around the single leg heel raise endurance test. The average number, which we've kind of always known, and this actually confirmed it, we want people to be able to do around 25 single leg heel raises. And if you go to, there's a link in one of the papers, but you can put in the patient's information into a web link, and it will give you what that patient should be able to do as a single leg heel raise, which is great to be able to compare their current function with where they should be. So yeah, single leg heel raise. I always look at foot strength. And if you have no equipment at all, you can do that by testing big toe strength. So the big toe, or the hallux, is like a marker for foot strength because 40% of the foot muscle volume is dedicated to the hallux, so nearly half. So if you want to test foot strength, if you look at big toe strength, it will give you a very good idea about that person's general foot strength. It's also been linked to their lower limb capacity. There's been a study where they found that the hallux flexion force was linked to the person's general lower limb capacity. So foot strength is a little bit like a handheld dynamometer test for upper limb strength. Like a hand grip test will tell you something about shoulder strength. Big toe strength will tell you about the person's overall lower limb strength quite often, which is why it's so useful. I look at inversion and eversion. Just manual muscle testing is fine. You want a ratio of 1-to-1 if possible. So if one side is much weaker, you need to bring it up to match the other side. And I'll also look at hip quite often with foot and ankle patients because the hip and the foot are very intricately related. The forefoot has to stiffen when we are walking or running in order to propel us forward. And then that works with the hip, with the gluteus maximus, for example. So the hip and the foot are quite related. I'll always look at hip extension, hip abduction, hip control if someone has a foot injury, because often the foot can be sore because the hip is weak or vice versa. And again, if you have someone with a hip problem, rehab their foot and it will help. And then finally, I go to things like palpation. But by that point, I usually know pretty much what I'm looking for. I leave palpation till the end because often if you start prodding and poking things, it can make them sore and it can affect how they function. So I tend to leave it till the end. And it's, for me, the palpation is more a case of ruling things out. So I'm just checking what isn't sensitive rather than what is, because by that point, I usually know what the problem is after doing all those tests.
Okay, that was a lot. I didn't want to interrupt you so you could continue your line of thought. So I just wrote down a few points here to ask you. So first on the subjective, when you say to offload the foot, So how do you go about that? Do you have someone that you go to and like buy those different like insoles, or how do you do that? Do you do that on your clinic if you have to offload different parts of the foot?
Yeah. So I can't think a good example of a foot problem that people will see regularly, and one of the most common ones that I see is plantar fasciopathy. That's really common, and physios do get presented with that quite often. There's pretty good research to show that a simple over-the-counter orthotic or an orthoses can be quite effective for certain people. So it's a really easy go-to, and you can buy them from various different places. I mean, Amazon sell them. There's lots of different makes, but there's kind of quite a standard prescription of orthoses, which doesn't have, or it might have a mild heel lift, a little bit of arch support, and be kind of medium density. And that will be good for a lot of people for various different reasons. We definitely know that there's not the one orthoses for one type of foot. So we probably want to look less at people's foot type, whether they're very supinated or very flat, and prescribing things for foot type. That's old-fashioned now, and we know there's not research to support that. You need to go with patient specifics, and often things that we think will work for people won't. Like a good example is patients who have hypermobility spectrum disorders. Often you give them something which you think will work, like a more supportive orthotic, because they've got foot pain, and actually it makes them worse. So you never know how a patient's going to react, and it's hard to predict. So it can be a bit of trial and error. So I will often use just a simple over-the-counter device that you can buy for not very much money. The other things, if it makes them feel worse, they can just take it out. So it's a low risk, treatment. If it's anything that I'd previously, so let's say 5 years ago, before I became more experienced, because now I can actually prescribe orthoses depending on the person and the pathology, but anything that I felt it needed more specific assessment, I would refer to a podiatrist, because that's their area, that's what they're trained to do. So you really want to refer to a trusted sports podiatrist if you can, and it's good to have those networks and those pathways set up for when you need them. There's a company that I work with now called TaylorMade, who make a range called it's called Kinetics, and they are very cleverly designed, because rather than being prescribed via foot type, as I said previously, we might have done that 10 years ago, they're designed to be prescribed for pathologies. So if you are a registered health professional, if you have the diagnosis correct, you can then prescribe one of these orthoses without having to do a lot of orthose training or a lot of podiatric training, and prescribed by what the injury is. So whether it's a tib-post tendinopathy or a midfoot OA or a metatarsalgia. So there are companies that do that now, where they have orthoses which are, it's somewhere between a full podiatry assessment and just getting something off the shelf, where you have an idea of what the pathology is, you know more or less what they need, and then you can prescribe for the pathology itself, and the orthoses are designed for that pathology. So something like a tib-post tendinopathy tends to have a higher arch support. It has a medial heel skive at the back, which helps support the rear foot. It has a dropped first ray. There's all things that are put into the orthoses for that particular pathology, which should help those patients better than something just off the shelf. So so you have a range. You can, like I say, something off the shelf might help. It often does with a lot of people. If things like anterior knee pain, patellofemoral pain, and a range of foot pathologies. Or you can do something in between the two, or you can refer to podiatry. You just need to know your scope of practice, I think. And if you're really not sure, then refer on.
Okay. And then we are talking about the objective measure of dorsiflexion. You said knee to wall, right? Or something like that was the name. And then you measured the distance to the wall. So how do you do that test? I was just trying to imagine. So you just ask someone to squat down. What do you do?
Yes. So the other name for it is the weight-bearing lunge test. So you might know it as a different name. In England, we tend to call it knee to wall, but I know in Europe they call it a weight-bearing lunge test. So the most standardized way of doing it is you get somebody to face a wall, kneel down on the leg that's being tested. So they're in like a lunge position, and then they place their foot in front of the wall. It's very important that the wall doesn't have a skirting board, you know, those little boards, that because that makes a difference to the measurement. So it has to be a flat wall. And then they lunge forward so their knee goes over their toe, and they touch the wall with their knee. And if it's easy, they would shift their foot back a bit. So the idea is to get them to the final point of their range of motion where their knee is over their toe and they're touching the wall, but their heel isn't lifted, and also their foot isn't too pronated. So you want the foot can pronate a bit, because pronation is a normal part of movement that helps us with our dorsiflexion. So if you keep them out of pronation completely, it will actually affect the score a bit. But if they drop heavily into pronation, it will give them a bigger score. So you just need to be aware of that. And people that have very flexible feet will often pronate more. So, but then that's part of your assessment. Then you know they have a flexible midfoot. You know that they have lots of pronation. Then you can test that with something like a balance to see if they can control it. And if they can't, that gives you rehab. You have to give them pronation exercises. So the quality of the way they do it is also important, not just the measurement. And also, again, as I said, where they feel the block. So once they get to that point, is the block in the front of the ankle or the back, or is it the inside? Because that will give you a lot of information about, especially with ankle impingements, or if there's a forefoot problem and their dorsiflexion is affected, often lack of dorsiflexion can load the forefoot more. So if they have very small amount of dorsiflexion, you know that the forefoot problem might be driven by the ankle dorsiflexion, lack of range. So that, again, that informs rehab treatment strategies going forward. So yes, does that explain the knee to wall test clearly enough?
Yeah. No, that's perfect. And then you mentioned some imaging on the bone stress injury. So like, when do you refer them to have an image exam? When do you suspect of something?
Yes. So with bone stress injuries, for the populations that I work with, or if you work with any kind of sporting population, but particularly if they're in an aesthetic sport, so gymnastics, or dance, or ice skating, or endurance sports, so marathon runners or triathletes, those are the cohorts where, if you're a physio in those worlds, you'll see bone stress injuries all the time anyway. So hopefully you're aware of what you're looking for, and it will naturally be higher on your index of suspicion than somebody who doesn't work in those sports. But everyone should be aware of it, because these are the injuries that doctors miss, because they probably just don't have the time to go into the history to really work out. I've seen metatarsal bone stress injuries which were diagnosed as just a soft tissue bruise by a doctor, and a dancer was given a can of freeze spray just to spray on her foot before she danced, and it was quite a serious second metatarsal bone stress, as she had a fracture. And it was, for someone who sees them all the time, which is me, it was apparent the second she said where her pain was. And I could see, because she had swelling over the dorsum of the foot and she'd limped into the clinic. So I knew straight away, but I see them all the time. So of course it's your experience in those areas. So I'm not surprised people miss them. They're not necessarily easy to pick up, but if you're aware of them and you know they're a high risk of presenting in those populations you work with, you probably won't miss them. But imaging wise, it's difficult, because ideally, probably the best imaging to go for would be an MRI. And the reason for that is it shows bone marrow edema. So if you have a very early bone stress reaction, that won't show on an X-ray. X-rays only have a sensitivity of about 30% for bone stress injuries. So people all the time, they get X-rays and they say, oh, the X-ray was clear, so it's not a fracture. Like, no, that's not true, not at all. X-rays can only rule in fractures. They can't rule fractures out. So if you have someone that you think might have a tibial stress fracture, or a metatarsal, navicular, talus, sesamoid, all of those things, X-ray is often done first just to check. But if it's negative and your history matches a bone stress injury, and if the patient has a medical history that supports that as well, so if there's any signs of red S, for example, and I had a negative X-ray, but I thought it was a bone stress, I would still treat it as a bone stress, because it's just not enough evidence. So the MRI is useful, because if you have a bone that is overloaded, it will glow white on T2 weighted imaging. So that's the fat suppressed imaging. and it's really easy to see. So it basically shows a bone that is bruised. So if you have an early bone stress reaction, MRIs will pick that up beautifully. The other thing that you can use is point of care ultrasound. So in the hands of someone who's experienced, because it's operator dependent, especially like the metatarsals, because they're so superficial, the ultrasound can pick up periosteal bruising and bone marrow edema and things like that. So you could use point of care ultrasound. If that showed some kind of stress reaction, that person would probably then say MRI advised. So usually MRI is the most useful imaging. If you don't have access to that and you still think it's a stress fracture, treat it as a stress fracture anyway, because if you don't do that and it will progress and get worse, or it will take a lot longer to improve. And a lot of the dancers that I see don't have the money to get an MRI quickly. And if we refer them in England on the NHS, it can take 12 weeks. So by that point, if you've treated it as a stress fracture anyway, they'll be better in 12 weeks. So you can't wait for imaging all the time. Sometimes you have to say clinically and objectively, this looks like a stress fracture. I'm going to treat it like that because I don't have the evidence that it isn't. Now, you might be wrong and it might just be a bursitis, which has happened to me. But that will get better. If you treat it like a stress fracture and you offload it, it'll be great in about 3 weeks. Whereas a stress fracture might be a bit better in 3 weeks, but it depends as well what grading of stress fracture. So without imaging, you can't grade a bone stress injury, but you have to assume there's a fracture. Depends on the timeline. Sorry, I know it's so complicated. I'm going back and forward, but if someone's only had pain for a week and it's quite faint, you've picked it up quickly, it might be like just a bone marrow edema, so a bony bruise. But if they've had significant pain for more than 4 to 6 weeks, there's swelling over the top of the foot or around the ankle if it's a talus, they can't walk, it's affecting their performance. That's much, much more likely to be a fracture. Mm-hmm. And fractures obviously have to be offloaded longer than bone marrow edema. So all of this it takes a lot of clinical reasoning and experience. Ideally, unless you're very experienced in dealing with them, it should be referred to a sports medicine doctor or an orthopedic surgeon to help with those decisions, imaging decisions, offloading decisions, return to play decisions. So you shouldn't really be you definitely shouldn't be managing a bone stress injury in isolation as a physio. Bone stress injuries are a multidisciplinary team effort to get better because they also require things like blood tests, sometimes DEXA scans, nutritional information, psychological input. So they're one of the more complex, difficult injuries. It's also why I enjoy treating them. They're very interesting to treat, and you get to work with lots of different disciplines. So I'll usually refer to a sports medicine consultant for those more than an orthopedic surgeon, but it just depends on who your contacts are, what your pathways are. But as I say, if you think you've got a stress fracture, that would warrant a referral either back to the GP or to the right person to help you manage it. So it's not something you'd be managing in isolation anyway.
Yeah, it's funny because as you were talking, I was thinking about myself. I was a gymnast. I used to do artistic gymnastics, and I had fracture on the 5th metatarsal head on both feet, and they missed it both times. But then on the second time, I was a little more aware of like, okay, I think that's because got an x-ray, they didn't see anything. And then they were like, oh, that's nothing. And then I couldn't walk. I couldn't load my foot for like weeks. And I would go back. I was like, still hurting, still can put my foot on the floor. And then they did an x-ray and it was like, oh, here is a small fracture after like weeks. And then the same thing happened on the other side because of the sport and the type of movements I was doing. So I think that is very common. It happened to me twice.
Yeah, and they picked yours up when it progressed to a fracture because they were using x-rays. So they didn't see it on an x-ray. Whereas if they had done an MRI at the beginning, they would have seen the bone marrow edema, the precursor to the fracture. The metatarsals are an interesting one depending on your sport. So military recruits tend to get metatarsal stress fractures in the 2nd and 3rd because most of what they do is marching on the sagittal plane. So they just go forwards, like people in the army. Footballers and dancers and gymnasts get them anywhere, to be fair, but they also get the 5th. They get the lateral because we do more lateral movement change.
You're twisting on the air, so like I have to leave the floor and twist and do like something else. So like I have a lot of, twisting and jumps and stuff like that.
Yeah, so the sport will give you a bit of an indication, and ballet dancers who dance on point might get the second metatarsal stress fractures more because the second metatarsal is taking a bit more load in that point position. So knowing your sport and knowing what's normal for it is also really useful for helping diagnosis too.
Yeah, very interesting. And then just last question about your objective. On the big toe, you do also manual muscle testing?
Yes. So unless you have equipment. So at the moment, there's still no gold standard for how to test foot strength. And we've been looking at it for a good 15 years. If you look in the research, there's paper after paper where very clever people have built dynamometers to measure the foot, but they're not commercially available. So that's great, but we can't use them in clinic.
Yeah.
There's going to be a paper published this year, which was done by the Australian Ballet team. And I forget the name of the lead author. Terrible. Well, again, we can link it in the show notes. But they looked at measuring foot strength on the VALD force frame. Are you familiar with the VALD equipment?
Mm-mm.
So VALD has lots of testing equipment: force decks, force frames, handheld dynamometers. And the force frame is kind of like a big dynamometer that's set up in clinic, and it has pads that move and change positions. So you can set it up to put the big toe into slight extension. So about 30 degrees of extension for the big toe. You can sit the person so their hip and knee are at 90 and the ankle is at neutral, and they just push their big toe down onto the pad. So it's quite a specific setup, but the force frame allows you to do that quite easily in clinic, and they're quite available now. People have force frames a lot of places in London that friends and colleagues of mine work in, and we have one where I work. So there is equipment out there to do this, and it's starting to become more available to clinicians. But in general, most people won't have access to that. So manual muscle testing is fine, and I do it in 3 different ways. So I have the foot in neutral. So the person sitting on the couch, I take the foot into neutral, and I support the big toe with 2 fingers, and I just get them to press the big toe into my fingers. And you can tell a lot from that test. Are they able to produce force? Does the big toe claw? So if the tip claws but the rest of the foot doesn't push, that shows an extrinsic muscle bias. Now, whether that matters or not depends on the person, etc., but I always look for that. There tends to be a pattern where there's an extrinsic muscle bias because the extrinsics tend to be able to produce force more easily than the intrinsics in a pathological foot. That's the pattern that I've seen. There's no research to support that I know of. And often that's why we bias the intrinsics when we train the foot. So we want to try and get the flexor hallucis brevis, the intrinsic muscle, to work hard so that the FHL, the flexor hallucis longus, isn't doing all the work. A good example for that is in dancers who have FHL tendinopathy, or runners as well. Runners get that quite often. So I test the big toe in neutral. I then get the person to curl their big toe over my 2 fingers. So this biases the FHL, goes into that clawing, and I pull up against it. And if they are unable to do that, that in the past has shown me that person has an FHL tenosynovitis. So if the tendon is irritated and sore and inflamed, they often can't isolate that movement. And that's, in the few people I've seen it in, that matches clinically every time. So that's a good one to look out for. And then the last one I do is I get them to point the foot down to full plantar flexion. So I do this with dancers, obviously, but non-dancers too. And I say to football players, point your feet like a dancer. So they point their feet. And then I try to pull the big toe up. I say, keep your big toe in that position. And I try and pull the big toe up. And what that does is it biases the intrinsics. So because the foot is in plantar flexion, the extrinsics are they're at the inner range, which makes them a little bit less able to produce force, which then means the intrinsics can produce more force. So that's why it biases the intrinsics. And that's the position where people get foot cramp. So you try and pull their foot up and they go, and they pull back and their foot cramps. And anyone who gets a foot cramp when I'm testing them, I think, right, foot rehab. So it's a good way. And for them, it's a good, because when you say to them, your foot is cramping because it's weak. And then the patient understands why you're giving them foot rehab. So it's a good way to get buy-in with them.
Mm-hmm. Very specific, right?
Very specific.
Yes. And now trying to jump to rehab, I know we talked a lot about objectives. So maybe in general terms, how would you approach these conditions? I know you can't talk about all of them, but you mentioned a lot of foot rehab. So how do you do usually, maybe in general?
So for rehab, this goes back to your diagnosis as well. So if you have a clear diagnosis, it does help you to give the patient a prognosis. So we can say a tendinopathy will probably be a lot better in about 10 to 12 weeks, or a bone stress injury is going to take 16 weeks, or a joint that has some synovitis 2 to 3 weeks, or a neuroma, who knows, because they're so difficult. So neuromas are one of my least favorite things to treat, because it just depends on the person. You never know how it's going to go. Neuromas can get better in a few weeks, or they can still be painful 4 years later, and they're very hard to manage. So anyway, so the diagnosis informs the prognosis. If you know exactly what you're dealing with, I think it helps you be more specific with the rehab. And I think that helps outcomes. But again, there's no research to show that. And there's a lot of talk in physiotherapy about how we just have to calm things down and then build things back up again. And I agree. I do that all the time. But usually I know what I'm calming down, why, and I build it back up with that tissue in mind quite specifically. There are a few cases where it's less easy to be specific. And in those cases, you still do that. You pull them back to a point where they feel comfortable, and then you build them up slowly. So I don't think diagnosis always matters, but I would much rather have a diagnosis. I'm clearer with my thinking in my rehab if I know exactly what's wrong. I just find it easier. I don't like the muddiness of not having a clear diagnosis, but you certainly can rehab without it, going off their symptoms. So general rehab, I'm looking at calf capacity, so calf strength. Strength and endurance are different. And again, it depends if you're working with a sporting population. Most people that work with high-level athletes have access to equipment where you can really test things objectively. So for calf strength, you're looking for an isometric plantar flexion in a seated position for the calf. You want people to be able to produce at least 1.5 times their body weight. If they're a big sporting, high-level athlete like a rugby player, you'd want that to be more like 2 times their body weight. So when you're rehabbing them, have that in mind. One thing we do constantly with the foot and the ankle is we underload it. And there was a paper that was published this year by Osborne. I know the name of that one. And it talked about, they did like a review and they looked at foot and ankle loading over a series of years. Most of the exercises involved ankle plantar flexion, but there was also foot rehab in there as well. And most foot rehab involves the short foot exercise where you lift the arch of the foot, or the toe curl exercise. And if you look through the literature the last 10, 15 years, those are the exercises that get used. They're my least favorite exercises for the foot. They're just not very good. And when I teach about foot rehab, I teach people every other version of what you can do apart from those two. It's ironic because they're the ones that have been studied. Mm-hmm. Sorry, I went off. Oh yeah. So with calf, what did I say about underloading? So we underload the calf all the time. The calf can produce 2 times our body weight when you test it. But when we're doing functional activities, that goes up to 12 times our body weight when we're cutting, changing direction, hopping, dropping down from something and pushing off a single leg. The reason you don't have to rehab them with 12 times their body weight, because that would be insane, is because when we say 12 times body weight is produced in the Achilles tendon, what we mean is it's the internal forces. It doesn't mean you have to get someone to lift 12 times their body weight to train that. And it has been shown that if you get someone to lift 2 times their body weight, it will produce internal forces in the tendon of 8 to 12 times. So long as you're training them with heavy loads up to 2 times their body weight, that will prepare someone for returning back to sport. But far too often, we don't give people heavy enough exercises for the calf and the foot, particularly the foot. I think the calf is getting better, but the foot is chronically underloaded. Part of the reason for that is you need equipment to do that. So if someone doesn't go to the gym, it's very hard to load them up with double their body weight. But
that's what I was going to ask.
Yeah, I've even given people, this is kind of crazy, but I've given people exercises like mums at home who have an Achilles tendinopathy. I've got them to put their kid on their back and do calf raises with the baby on their back. So they have some kind of weight, and it's fun. And mums have no time. So I was like, let's do something that can involve your 2-year-old. Get your 2-year-old on your back and do calf raises with them. I've done that with people. Or you can get backpacks and you can put a bag of potatoes, a bag of sugar, a bottle of water, just to give them some kind of load. So there are ways of doing it. Or you can buy, like from a building company, you can buy a big bag of sand, which weighs 20 kilos, 25 kilos. And then they can put that on, somehow there's ways of getting load into people. It's not easy and it's a barrier. So whenever you have to get someone to do that, it relies on them committing and doing those extra things. But if you can convince them that it will help them, then you can get some patient buy-in. And most of my patients are amazing, and they really do stick to what our plan is. But I think part of that is because often by the time they're seeing me, they've tried other things. And there's probably a little bit of sway of when you say, oh, I teach this stuff, so I really know, they believe me a bit more maybe. But also I think the fact that I believe in it, so I can sell it to them. I think if you believe in your treatment, you're always going to sell it better to your patient. And I'm very, very much biased around rehab, control, activity, anything that can be patient led. So I use manual therapy, mobilizations, all that all the time. But my bias is absolutely rehab and return to sport. And those are the important things. So so the loading, you asked about the rehab. So load people heavier. So for the calf, like I said, just a simple double leg heel raise is so low, such low load. Of course, if they can't tolerate a single leg heel raise, you have to do a double. But as soon as they're ready, go to a single. As soon as they're ready, load them up. And for the calf, make sure you're doing straight leg calf raises and bent knee calf raises. Really important. And that doesn't mean you need a seated heel raise, a seated calf raise machine. You don't need that for people to do a bent knee calf raise. If you just get them to bend their knee and stay in that position as they rise up and down, you're getting a bent knee calf raise. It's harder to load it heavy because they're not as stable as if they're in a machine. But you can certainly give them a backpack with 20 kilos on it and do that with them supporting their weight on the wall. And that is something I do all the time because most people don't have access to a seated calf raise machine. But the reason we want to train dorsiflexion in the calf is not because it trains the soleus. It does, but it also trains the gastroc. The reason we want to train dorsiflexion is because that is the functional position that we use the foot and the ankle in. That's the position that you get Achilles tendon ruptures. That's the position that you get Achilles tendon tears or calf tears. And the calf can produce the most amount of force in dorsiflexion. So if you train dorsiflexion, and you do need a bent knee to do that, you can do a straight leg off the edge of a step, but it's not the same as having a bent knee. So the reason to train it is the functional driver, because that's the position that people get injured in sport, and that's what they have to get back to. And then for the foot and the ankle, I've got stuff online that people can see. But the short foot exercise and the toe curl exercise need to be forgotten about. But there's much better options. Banded big toe work, any kind of balance, foot bridge, where you put the foot with the front part of the foot and the back part of the foot onto anything, a weight plate or a book or 2 blocks, add load to it. The final thing I'll say for the foot is the toes and extension is the position to train the foot in, because again, that's functional. That's where we produce force. When we run, our toes go into 50 degrees of extension. So training the toes in a toe curl, an unloaded toe curl couldn't be further from what we have to do functionally and in sports. So if you can, and so basically it's a calf raise position, isn't it? So if you just do heavy bent knee calf raises, you are training the foot. But you're probably biasing the calf a bit, and there's ways to bias the foot, probably beyond the scope of this podcast. But load heavier, be specific as you can, and train the calf and dorsiflexion.
Okay. And then you said that you also do manual therapy. So sometimes if you have to gain range of motion, do you use more manual therapy, or it depends?
Yes. So actually now, because I see people more like a second opinion, I'll assess them and then I'll write a letter back to their usual physio, and I'll say, do this. So I say to them, add in this type of manual therapy rather than me doing it. I do it with some of my patients, but often I'll be advising the physios that have referred to me, and I'll say, try this, try this, try this. But there's good research for manual therapy in foot and ankle injuries, and everybody took their hands off and they said, we're not going to do manual therapy anymore because it doesn't work or it doesn't give long-lasting effects. But there's research to show that manual therapy can improve balance, it can improve dorsiflexion. So Maitland mobilizations or Mulligan MWM mobilizations have both been shown to improve outcomes in chronic ankle instability. So I will use both of those, and then I'll give the patient a version of it if they can to do by themselves before they do their rehab or something. I also use, so Mulligan MWMs are the ones where you fix the talus if the person's foot is on the floor, and then they lunge forward and you glide the tibia in a posterior to anterior direction over the talus. So there's a taping technique that you can do if that's useful for patients. You can use a taping technique called a talar taping technique, where you effectively tape the talus in the same way as where your hand would be. And it's important that you show the patient exactly how to do it. The taping stays on for a short amount of time, no more than 5 minutes, but you tape it with rigid tape. They walk around or they go on a treadmill for 5 minutes, and it just helps mobilize the ankle a little bit. I don't think we know the exact mechanism. Technically, we're saying it is moving the talus posteriorly. I don't think that's what's happening. I think it's a symptom modification. But for some people, for anterior impingements or restricted dorsiflexion, it can be really useful. And it's something they can do themselves. So I've given that to a gymnast who used to use it before he went to train, and a dancer before she started dancing. So she'd get to class early, tape her ankle, walk around, take the tape off, and then it meant she could plie without pain and she could jump without pain. And then usually time does its thing, things start to settle, and then they don't need to tape. And it doesn't work for everyone, but it works well for some people, so it's worth trying.
Mm-hmm. Okay. And when you're talking about doing those exercises that are not in a functional way, I never thought about it, but makes total sense. What are some other common mistakes that you think people, PTs, do in the foot and ankle rehab?
So when I teach my course, there's a section I talk about this because I thought it was a more interesting way of discussing it. If I say, these are the things that I see that I think we could do it better, and it gets people talking about what they do, and we can talk about how you might change it. And one of the first thing is the underloading, which we've already talked about.
Mm-hmm.
The next thing would be more in acute stages of injury is treating the inverters and the everters, so the tibialis posterior and the peroneals, as if they were primary movers. So what I mean by that is I'll often see ankle sprains, say 3-4 weeks after the sprain, and I say to them, what rehab have you done? And they say, oh, well, I had a yellow band and I had to just sit and pull my foot in this position, or they had to pull it out against the band. And there's a few things that I think we could do better than that. So first of all, a yellow band is very, very low load. And it's very high. It's high repetition, low load, and high range of motion. And if you think for an acute to a subacute ankle, you might not, you especially in the acute stages, you don't necessarily want them to go to their full range of motion because the ligaments are healing, and everything's trying to kind of heal after this nasty traumatic injury. So pointing the foot into a TheraBand, into full plantar flexion when you've had an ATFL rupture, effectively means that it probably won't heal as well. I don't know for sure, but once the foot goes into around 30 degrees of plantar flexion, the ATFL is on a full stretch. So if you're particularly dancers who have a big range of motion, if they're pointing their foot all the way down and then coming back up, you're not allowing the ligament and the capsule, because the ATFL is part of the anterior capsule, to heal in that closed position. And I think that can sometimes contribute to ongoing laxity down the line and chronic ankle instability. But if you can load it in a more neutral position, like with body weight, and just work more on proprioception and balance corrections, then I think that's a more useful exercise and more likely to have better outcomes going forward. So I still work the everters, but I do it isometrically rather than isotonically going through range. And I keep it isometric in eversion. And then I add a little bit of plantar flexion and dorsiflexion. But for the first 3 to 4 weeks, I say don't go past about 30 degrees of plantar flexion. And I just keep the ankle in a slightly more stable position. Absolutely keep it moving because you don't want it to stiffen up. And then for the tibialis posterior, that muscle is huge and it can take a huge amount of weight. It can take up to 35% of our body weight. You can rehab it to be that strong. And if someone has a tib post tendinopathy and they're using a yellow or a red band to do inversion with the foot in dorsiflexion, then number one, they're using the tibialis anterior much more, especially if the tib post is already, weaker. And two, it's not strong enough. It's not going to give them strength gains. And actually, you're probably not adding much to their rehab. It's probably just time that's getting them better. But if we can load the tibialis posterior, thinking about it as an antipronation muscle rather than an active inverter supinator muscle, then that means we would load it in a closed chain position, controlling the arch. So I get people to drop, what I was saying about allowing pronation. So I get people to stand on a single leg and allow their foot to go into pronation and then bring it back up into supination with body weight on it, much harder than a banded exercise. Then we'll load it. Then I'll add something like an incline, so a step which actually gives them 10 to 15 degrees more range into their pronation. So it's higher at one end and lower on the inside of the foot. And then they can really go into their pronation and pull back up against it. So they're working the subtalar joint, because that's where your pronation and supination comes from. And the tibialis posterior is being challenged in a functional way. That's how we use it. It needs to control that pronation and help us supinate as we push off. And I just think that it helps to, I don't have evidence to show it, but I think it contributes to ankle stability and better function when they get back to those higher levels because they've been trained in those positions. We don't use the foot in an open chain position, wiggling it in circles. We use it to take load, to absorb our load as well. So when we land, the foot needs to be really robust and needs to absorb through the midfoot, go into pronation, then come back out of it. And that uses the plantar fascia, the Achilles tendon, the tibialis posterior, all the ligaments. So if we can train it like that, I think we will get better outcomes.
And I think it all goes back to being functional, right? What you're describing is just going to more functional positions that you're going to use versus you're just doing an inversion, open chain.
And now I've said that, there is a case to isolate muscles when you need to. So if there's a real strength deficit, and especially if you can test people objectively and you can say, okay, the tibialis posterior you're only able to produce 15% of your body weight through it. We need it to be 35%. Let's isolate that muscle and let's get it stronger. But we would load it with weights or much heavier therabands, rather than just these little sort of winging movements. So I do think there's a case to isolate muscle groups if you find a deficit, which might be limiting their function, but then bringing it back to that functional training at the end is the important part.
Mm-hmm. Yeah, no, makes total sense. Anything else on the mistakes? Or it's pretty much...
Yeah, well, I have one other. And this comes from something that I did wrong. And I saw it. I saw how it affected the patient negatively when I did. This is how I learned it. Years ago, I had someone with a really nasty ankle sprain, and I'd gotten to the point where they were able to do single leg heel raises. They were feeling much better. Their stability. They were basically ready to jump. And I was like, right, let's do pogo jumps. So I got her to do, springy, fast pogo jumps, and it flared up her tibialis posterior tendon, and she lost loads of dorsiflexion, and it was a massive, massive problem. And I realized later when I researched it with more experience that she was ready to jump, but she wasn't ready to do repetitive explosive jumps like a pogo jump. And what's interesting is the reason I had given her that is because that's what I had seen other people do. She had a particularly nasty ankle sprain, so she was probably more likely to get flared up. But I see it all the time where once people are ready to jump, they're given pogo jumps. And sometimes that's fine and people get better and they get back to sport, no problem. But if you have someone who is a bit weaker or it's more complex or whatever reason, it can really flare things up. And now that I've studied it in more depth, when you look at jumps and plyometrics, it's so important to, if the person has been immobilized, let's say for 8 weeks in a boot, and they've been injured, they've atrophied, they haven't used their tendons for months by that point in a springy way, and then you give them repetitive jumps, you haven't prepped them for that. They might have a basic strength, but if you haven't worked on rate of force development, so the speed that they can move, and if you haven't worked on their ability to recoil, so worked on the springiness of the movement, and you just throw everything at them in one go, you've missed a whole step. And that's what I did. I missed out a whole step of rehab. And like I said, some people you do that with and they'll cope with it. But the trickier ones, it's so important to really identify the fact that they haven't jumped. The girl that I'm talking about hadn't jumped for 9 months at that point. So there's no way she was ready to do repetitive fast jumps. What we should have done was say 6 to 8 weeks leading up to that point was work on her speed of movement, so get some rate of force development in there, so just the speed she was doing her calf work, some landing work, get her to do box jumps, so just one quick jump up to a box, get that speed into the tendons, get her stronger. Power is a mixture of strength and speed, so it's fine to have strength, but you have to work the speed element, otherwise you won't have the power. But you have to train that specifically, especially if they're coming from a big injury where they haven't jumped for up to 9 months. So I now break things down, like I said, landings, takeoffs, speed of movement, and then I very slowly bring that back together. So actually, if anything, the fast high pogo jumps are at the very end of that. There's a whole stage in the middle that you can train people up with, so that by the time they get there, their tendons are far more robust and less likely to flare up. It's the tendons that are the problem, because that's what's going to stress the tendons the most, is the fast plyometric movement, very short stretch shortening cycles. That's a plyometric activity, and that's what pogos are. But you have to train that leading into it. Don't go straight into it. So learn from my mistake and do add in a whole section that preps people for plyometrics.
Yeah, it makes sense. It makes sense. And I know we plan to maybe talk a little bit about dancers, because I know it's your specialty. We've been going for a little while. So what do you think? Do you want to mention anything about the injuries on the dancers, or any special tip? Or you think you mentioned a little bit through our conversation too, some things. Anything else that you want to add in that regard?
I can do a quicker summary if you want. So just the most common things that I see in dancers, if anyone's interested in working with them, these are the things that you'll see the most. So I've already said HL tendinopathy, definitely. Posterior ankle impingement, which is usually a secondary to an ankle sprain, and it tends to present around 4 months afterwards. So you're all good, you're rehabbing, and then they get into the end range activity and they start to ramp up their exercises, and then they'll say, oh, my ankle hurts when I point my foot, and then you know you're dealing with a posterior ankle impingement. You do get lots of Achilles tendinopathies in dancers, and Achilles paratendinitis, which is the sheath, when the sheath gets irritated. Patellofemoral joint pain, so anterior knee pain. Medial tibial stress syndrome. If you work with adolescent dancers, it will be the only thing you see in September when they all go back to college. Bone stress injuries, we've already said, very high prevalence in that population. And the other thing is shoulder injuries. So because of the hypermobility prevalence in dancers, and often there's people that have like Ehlers-Danlos syndrome, some of them, or more severe presentations of a hypermobility spectrum disorder, and often they will present as subluxations of joints. So patella and shoulder are two that I see quite a lot of.
Okay, great overview. Anything else you want to add on management, or you think you're...
for the dancers.
Yeah.
The key thing is for dancers is that it's very different working with students or professionals, and I work with both. Students compared to professionals are so easy because if they're injured, you can just take them out of their class. Professionals, you can't do that. That's their job. They have to pay their rent. And so if you say, taking them off or out of a show is a really big deal. So you have to be really clever and creative and know how to keep people working around injuries, more so with professionals than students. But also when people get to the level of being professionals, they often know their body quite well. They're far more experienced dealing with injury because they will have had an injury by that point. So I can't, not to go into too much detail, but that is one of the big challenges of working with a professional cohort. But then also knowing when they do have to stop and having the confidence to say you can't go on, or if it's a suspected bone stress injury, that's when I would say that. If it's not dangerous to dance on, i.e. it's not going to turn into a fracture, or it's not going to, the other ones that I've sent back too early and I wished I'd kept them off or asked them to stay off, because it's not really my decision. It's their decision. It's their body. It's their job. And I'm there to advise them. So it's not for me to go, you're not allowed to go on. But if it is a suspected high risk bone stress, then I will kind of say, I need you to really not go on, and this is why. But for something else, like a good example is a hamstring, like a high grade hamstring injury, strain, or a hamstring or calf strains, like a grade 2, where they've definitely torn something, it's sore, they warm up and it feels a bit better and they want to go back on. We know that those are so likely to re-injure. They just will. And in the past we've decided that a girl was going to go back on for a hamstring and she re-injured it in the show, and I thought, I knew she shouldn't have gone back on. I just knew it. But she wanted to dance and I just sort of crossed my fingers and hoped. And I always wish that I had gone with my knowledge, which was this will re-injure if you dance on it. I just knew it would. So, but it's very hard to make those decisions because they want to dance and you don't want to pull them off. So that's a hard thing. In any kind of professional sports, it's the same. But in terms of the management for dancers, the key thing is to try and prevent the injuries. And if you can, try to get dancers to cross-train like an athlete. That would be my main advice. And younger dancers coming up now, they're getting that input. It's exciting. New dance colleges have strength and conditioning coaches. They have education on their courses around anatomy, dance, injury management. I teach some of those courses at Trinity, Laban, where I work. So they've got much better knowledge, and there's a swing, like the culture has changed, and dancers doing strength training is beginning to become more of a norm now. But that would be the key thing. If you ever work with a dancer, if you can get them to cross-train in something that doesn't look like dance, so not yoga and Pilates. They love yoga and Pilates. And while it's good to do something, they would be better to spend their time, I think, on something like strength training, which has better evidence around it for injury prevention. Of course, it's very complex. It won't stop them getting injured, but it might help their facility as well.
Yeah, okay. And if people want to learn more about the topic, do you have any resources that you recommend, books, papers, anything that you like in particular?
My number one that I used to go to was Twitter, or X, but it's changed a lot over the last few years and it's not as useful as it used to be. But social media in general, if you follow the right people, is one of my favourite ways to get information and do CPD. Especially if you follow teachers, because often they'll tweet about or post about new papers because they're the ones that know about the area. And podcasts like yours, I do a lot of learning from listening to podcasts because it's just a more accessible way of finding the information. Mm-hmm. So those are ways that I still use now. I also follow for dance. IADMS is the umbrella body who have a journal which is called the Journal of Dance Medicine and Science. So I'm a member of IADMS, and they have a journal which gets published, which I kind of keep on top of because that's an area that I'm interested in. But I also, for general sports, I follow things like the British Medical Journal and the JOSPT, again, on social media, and I just do searches when I have time to see what's new in those areas.
Good. And any advice to clinicians that are starting their careers?
So probably my number one bit of advice, I was asked this recently by a student who was putting a handbook together for students going on their placements. And she asked me, what would be your advice? And this is what I told her. I just said, don't wait until you feel really confident, like you know what you're doing, to start treating patients, because that doesn't ever come. Like even for me, 15 years later, having been sports therapist and now a physio, there are days when I think, I know what I'm doing, this is great. But there are so many days when I think, God, I still have so much to learn, you know, and that confidence of being you, that's the other thing, is don't ever expect to be sure in medicine, and embracing the uncertainty is part of the job. And I wish I'd known that before, because human beings are complex and we don't know what will work for everybody, and we don't always know definitely what the diagnosis is. And even if we get the diagnosis, they may not respond to treatment as you were expecting for a multitude of reasons. So if being uncertain is fine, just make sure that you're not missing anything important. So don't miss a fracture, don't miss the referral that you need to make for an inflammatory pathology, or don't miss someone who has an infection. So when they come to see you because they've got a joint pain, but they've been ill, or they had something, you don't miss the red flags. So make sure you've screened for those, and refer appropriately. And so long as you know that the patient is safe, you just need to know that you won't ever know for sure if what you're going to do is right, or why someone didn't get better. Sometimes they just don't, and you have to accept it. It's a really difficult profession to go into.
Mm-hmm. Yeah. And I know you also have a course, right? So if people want to learn more about you, how they can find you and your course and all your information.
I have a website, which is lizbayleyphysio.com, and my name is spelt with a Y, Bayley. And then I'm on social media, same thing. If you just Google Liz Bayley Physio, you'll find me. So I used to be on Twitter, like I said, or X. I'm not so much now, but Instagram is the one that I think is the more fun place to be. So I will always publicize any courses that I do on Instagram. Anything, that's the main place I would probably do it. I don't have a mailing list. I need to start one, because I get inquiries all the time about my courses, and I just put them into a little folder. I need to do an official mailing list. I might start.
Awesome. Liz, thank you so much for your time. This was a great overview. I know we went over time, but it was so much information. It was great. So I appreciate so much your time, and I'm glad that we finally made it work and you came here to share all your knowledge, very specific, very focused, so really good. Thank you so much.
Thank you very much for having me.
That's all for today's episode of PT Pro Talk. We hope you enjoyed this discussion. Be sure to follow us wherever you listen to podcasts, so you'll be notified when we release future episodes. You can also join our email list at ptprotalk.com to receive updates and access new episodes. If you have ever gotten value from the show, please take a moment to leave us a 5-star review. It always makes my day, and it really helps us out. If you have any guests or topics you'd like to see on the show, let us know by answering a quick survey. You can find the link in the show notes, along with more information about our guests, resources, website, and social media. Thanks again for listening, and until next time.